Of introducing Dr. Ali Al Lawati. He's a nephrologist at the University of at the Sultan Qaboos University Hospital. He's a senior consultant, and he did his fellowship in glomerular-based disease, PD, and pregnancy and kidney disease at the University of Toronto. He's going to talk about the management of difficult to treat lupus nephritis.
Thank you, Dr. Sadiq, for the introduction, and thank you, Dr. Mona. Assalamu alaikum, everyone, and good morning. It gives me a great pleasure to be here today presenting at this international conference. My topic for today will be about difficult to treat lupus nephritis. The big button. So I'm going to start my presentation by talking to you about a case that I recently actually managed. So she's a 25-year-old woman, previously healthy. In June of 2019, she presented with generalized arthralgias. For that, she was actually referred to the rheumatology clinic. Workup there revealed that she actually had nephrotic range proteinuria, but not nephrotic syndrome per se, and she had a normal creatinine. Serological workup revealed positive ANA, anti-Smith antibodies, and low C3-C4. So she ultimately underwent a kidney biopsy, and the biopsy showed focal proliferative glomerulonephritis with crescents, full house immunofluorescence, so consistent with proliferative lupus nephritis. So at that time, the decision by the rheumatology colleagues was to manage her with six cycles of cyclophosphamide, which she received from October of 2019 to February of 2020. And with that, she actually achieved a full remission. So her creatinine towards the end of the therapy was 50. It was normal to begin with, but her urine protein creatinine ratio, which was initially in the nephrotic range, was 16, the normal being less than 15. So totally a normal proteinuria level. Once she completed her cyclophosphamide, she was then maintained on MMF, and she continued on MMF for a period of about 3 to 4 months. And then, issue of pregnancy came up. She was planning for pregnancy, so she was switched to azathioprine. However, in retrospect, when I went back and looked at her records, at the time when she was switched to azathioprine, she was already showing some signs of flare. Her urine protein creatinine ratio, which used to be 16, was already 130 at that time. So about 2 months later, namely in October of 2021, she presented with severe AKI this time and nephrotic syndrome, with her creatinine reaching 575 and urine protein creatinine ratio of 1,900, normal being less than 15. She almost needed dialysis actually during that admission. Biopsy was repeated, and again, it showed the same findings, proliferative glomerulonephritis with full house immunofluorescence. And this time, she had progression of her fibrosis to 20%, the first biopsy having not shown any fibrosis or maybe just minimal scarring. So she was planned for 6 additional cycles of cyclophosphamide since she responded well to it first time, plus intermittent pulses of steroids. And she actually, again, had an initial good response with her creatinine improving from almost 600 all the way down to 40, proteinuria from 1,900 all the way down to 120. However, while she was still getting actively her cyclophosphamide, I think in January 2022, she might have completed 3 or 4 cycles. So she still had 2 more cycles planned. She presented with a flu-like illness, admitted to the hospital, and was found to have, again, severe acute kidney injury with a creatinine of 400 and urine protein creatinine ratio of 2,500. So at that time, my rheumatology colleagues decided, maybe it's about time to try something else. So they opted for rituximab, and she received 2 doses of that. The first one was the standard 1 gram. The second one, she actually just received 500 milligrams because she has recurrent infections. In fact, most of these flares that I've talked about were always preceded by some kind of a viral prodrome. So frequent infections, low IgG levels, and she actually also had quite extensive genital warts. So they were worried about that, so the second dose was only 500 milligrams. With that, and remember, before that, she had also received 3 or 4 doses of cyclophosphamide the second time. Creatinine came down to 50, so at least the acute kidney injury part resolved, but her proteinuria did improve to around 1,000, albeit still very high. Once she completed rituximab, she was kept on maintenance myfortic, mycophenolic acid, 720 milligrams BID. So the myfortic would have been started maybe in June of 2022. By August of 2022, again, admission with a viral illness, fever. Most of the times we could not actually pick up a specific pathogen, nothing bacterial. Creatinine went up to 200 and her proteinuria again spiked to 2,700. And this is when I was actually involved. At that time, the first thing I did was get an ultrasound of her kidneys, which showed normal-sized kidneys and no renal vein thrombosis. So I'm going to stop here. We'll come back to this case at the end of the presentation. So before we talk about how to approach somebody with resistant lupus nephritis, just a reminder about the standard of care of treatment of lupus nephritis. These are the most updated KDIGO guidelines. So in addition to glucocorticoids, we can either use mycophenolate mofetil analogs, low-dose intravenous cyclophosphamide, that's the Euro-Lupus protocol. We can use either low-dose intravenous cyclophosphamide or MMF plus belimumab, and that's actually something new. Or we can actually use mycophenolic acid analogs with calcineurin inhibitor if the renal functions are not severely impaired. And here they give a cutoff of should be more than 45 ml per minute. So what is resistant lupus nephritis? So the definition of resistant lupus nephritis is failure of initial immunosuppressive therapy to achieve either a complete or a partial clinical response. So what is complete response? What is partial response? Actually, the definitions vary. They are actually more clear for for partial, because usually it means that their proteinuria is now subnephrotic. But for both of them, you need a reduction in urine protein excretion. You need an improvement or at least stabilization of the serum creatinine. And you also need an improvement of the urinary sediment. So they should not have microscopic hematuria attributed to their glomerulonephritis or RBC casts. And we must keep in mind that for a complete response, you need therapy for at least 6 months, sometimes even more than a year. So when should we suspect resistant lupus nephritis? So most papers actually mention the cutoff of 3 to 4 months. So by 3 to 4 months, if the patient is not improving in terms of their creatinine, in terms of their urinary sediment, in terms of their proteinuria, we should really think, could this be resistant lupus nephritis to the current medication regimen? This is another point that I have added myself. It's not really mentioned in any of the papers. But what if you're treating the patient and you know they're getting their treatment? Like they're coming to their daycare visit and you can see the IV cyclophosphamide going inside them and they're actually worsening on therapy. That should qualify as resistant lupus nephritis as well. So how common it is? So very important to know that truly resistant lupus nephritis is actually quite uncommon. And we have to keep in mind that resistance is often due to the other factors, such as non-adherence. That's when you use like oral therapy, like mycophenolic acid analogs, or inadequacy of the prescribed regimen. And we'll talk about examples of inadequacy of regimens in a bit. If you look at different papers, the prevalence of resistant lupus nephritis is anything from 3 up to 80%. Huge difference. But actually, if you specifically look at papers that looked at objectively at non-adherence, and when I say objectively, like for example, they measured the level of mycophenolate, or they measured the level of hydroxychloroquine, so you know if the patient is taking it or not. Many of the patients that were labeled as resistant lupus nephritis turned out to be actually non-adherence. Okay, so we'll come to the management of somebody with suspected resistant lupus nephritis. So as I said, we assess the adequacy of the patient's therapeutic regimen. For example, is the patient on hydroxychloroquine? Did they receive adequate glucocorticoid course? What if they are on mycophenolic acid analogs? Are they on the appropriate dose? So if you look at the guidelines for induction, they say that the dose should be 2 grams to 3 grams per day. how do we decide who gets 2 grams? How do we decide 3 grams? In my practice, we always aim to keep the patients on 3 grams, although that's sometimes difficult to achieve due to the medication intolerance. But what if somebody is on, you have to reduce their dose because of intolerance or cytopenias? Then what? Do we just continue the lower dose, or do we consider them on inadequate therapy, right? There are a lot of questions that we have to actually consider when that happens. We check for adherence, and my next slide will elaborate more on that. And then the third thing that one might consider is actually a repeat kidney biopsy. That would be at the cutoff of 3 to 4 months when you have established that the patient probably has resistant lupus nephritis. And why do we repeat biopsy? Remember, such a patient would have had a biopsy like 3 to 4 months ago. So why do we need to repeat a biopsy? 2 reasons. One, you want to make sure that you're still dealing with an active disease, and that, for example, their creatinine of 200, which is stuck at that level, and their proteinuria of 4 grams, which is also stuck at that level, is not because of scarred kidney. So the last thing you want is for your kidney biopsy to look like that, and you intensify the patient's immunosuppression. We're not really gaining here, we're just potentially harming the patient. And then also remember, with lupus, you can actually have concomitant pathologies like thrombotic microangiopathy, which may require additional therapies as well. So that's the main goal of a repeat biopsy. This is a table that I found in an editorial, actually, which I think is very nice. So it gives you some guidelines to how to improve adherence to treatment in lupus nephritis. So we all have to remember that actually non-adherence is the rule, not the exception. I'm sure everyone here in the audience has been prescribed a medication at some point, and even 1 pill a day is difficult to remember many times, okay? So, perfect adherence is really the exception. We also have to remember that non-adherence may lead to end-stage kidney disease, and that's something that we have to repeatedly counsel the patients about. We have to improve our diagnostic skills to unmask non-adherence. And one example here is always ask open questions. So for example, don't ask the patient, are you taking your pills or not? That is not, always helpful. Instead, what we can say is, I recognize that you have to take a lot of pills at different times of the day, and that's easy to miss. How many doses in a week do you think you forget, to take? And I find it actually, even from my own personal experience, that, patients tend to open up and be more honest about it if you ask them such. Use objective methods to detect non-adherence. So here they mention hydroxychloroquine levels. In my hospital, we don't have them. But actually, in my hospital, we can send blood samples abroad for mycophenolate levels. So that's something we can do if we suspect that the patient is not really taking their MMF. If we think they're not taking their steroid, one clue would be if they don't have any Cushingoid features after like 3 or 4 months. But, send a serum cortisol, and if the cortisol is not suppressed, they're probably not taking their prednisolone. Try to understand the reasons of the non-adherence, and then, set up a tailored management plan. So let's go now to specific scenarios. So what if the patient is actually being treated with MMF, and you've already established that they are resistant to this regimen? So the guidelines actually give you 2 options. One option is to switch to IV cyclophosphamide plus glucocorticoid plus or minus belimumab, which I'll talk about in a bit later, or continue MMF but add calcineurin inhibitor or rituximab. How do we decide? There are multiple factors that we have to consider: clinician and patient preference, drug availability, cost. Fortunately, in this part of the world, medications are covered for all citizens, so we don't tend to think about cost a lot, and medication availability as well, but in most parts of the world, these are major factors. Toxicity and tolerability. We have to keep in mind that there is no evidence directly comparing these regimens. I'm talking about specifically in the context of resistant lupus nephritis, and these guidelines are purely based on clinical experience and expert opinion. I am going to quote a few studies here and there, but you'll be surprised how small the numbers of patients who were enrolled into the studies. We're talking about studies of like 6 and 7 patients. And also, if you remember, these regimens are the same as those used for initial therapy. So with the exception of rituximab, which is almost never an initial treatment for lupus nephritis, all these regimens are there actually in the initial guidelines for treatment. So I found this study actually, it was of 17 patients only, and those 17 patients specifically had resistant to mycophenolate treatment. So they were started on tacrolimus, followed for 24 months, and at 24 months, 6 patients had complete response and half patients had partial response. Another 6 patients had a partial response. And tacrolimus was very well tolerated, which is what I see in my clinical practice as well. I personally like tacrolimus and I find it a very useful drug and well tolerated. Since we started talking about CNIs, maybe we should talk about this hot topic of voclosporin. So voclosporin, as you know, is a next generation CNI, calcineurin inhibitor. It's actually similar in structure to cyclosporin, but it's more potent. And the main advantage of voclosporin is that it does not require drug level monitoring. So how did voclosporin ended up being in the guidelines? And remember, it's in the guidelines even as a potential initial therapy in combination, of course, with mycophenolate mofetil. So we have the Aurora trial, which was an RCT of 357 patients. This is considered a large trial for nephrology. So patients were randomized to voclosporin or placebo along with standard of care. And here the standard of care was mycophenolate mofetil and glucocorticoids. And you can see that at the end of the study, rates of complete renal remission, which is here, and then this is the proteinuria, were all statistically significant. And this is how voclosporin actually ended up being approved for treatment of lupus nephritis. What about belimumab, another hot talk recently? So belimumab is a human monoclonal antibody that inhibits the soluble form of B-cell survival factor, which is also known as BLyS or BAF, B-cell activating factor. So FDA approved belimumab for the treatment of lupus nephritis. Again, not as a single therapy. It has to be always combined with something else, and that combination can be mycophenolate mofetil or can be cyclophosphamide as well. However, we have to keep in mind that the experience with it, clinical experience with it, is actually quite limited. And the approval of belimumab came from this trial from New England Journal of Medicine. About 450 patients were randomized to either placebo or standard of care. Standard of care here was both cyclophosphamide and MMF. And at follow-up of 2 years, complete renal remission was significantly actually higher in the belimumab group. So we'll move to the other group of patients. So patients we discussed patients resistant to MMF. We'll discuss now patients resistant to cyclophosphamide. So the guidelines recommend that they either be switched to MMF plus glucocorticoids. When I say MMF, I also mean, myfortic mycophenolic acid. Or MMF plus either CNI, belimumab, or rituximab. Again, the same rules apply here as before. There is no evidence directly comparing these regimens in resistant lupus nephritis. It's mainly based on clinical experience and expert opinion. I found this case series of 12 patients in which patients were treated with patients who were established to have cyclophosphamide resistance were treated with MMF for 13 months, and 10 out of the 12 patients had quite significant improvements in their proteinuria and creatinine. What if patients have resistance to both cyclophosphamide and MMF? Pretty much similar to the patient that I presented initially. So these patients, we have to treat them with rituximab-based regimens. Now, before I go into more details, I'm sure most of you are familiar with the LUNAR trial, in which actually rituximab was tried as a first line in combination with MMF for the treatment of proliferative lupus nephritis. However, what that study showed is that the addition of rituximab to MMF did not result in any renal endpoint improvement. So that's why we don't hear a lot about rituximab as a first line. However, rituximab has been, again, in very, very small studies, looked into for the treatment of patients with resistant lupus nephritis. to both MMF and cyclophosphamide. Here an example of 22 patients, or maybe 23 because the numbers don't add up, 23, that had resistance to cyclophosphamide and MMF. So they were treated with rituximab, and 5 of them had complete remission, and 7 of them had partial remission.
You have 1 minute left.
1 minute? Okay. Plasma exchange and immunoadsorption. So plasma exchange was in 1992 actually tried for severe lupus nephritis, and this paper in New England Journal of Medicine failed to show any improvement. So that's why we don't hear about plasma exchange in even the most severe lupus. However, if you look at some small studies here and there, immunoabsorption actually can improve. So patients who are resistant to lupus nephritis, to the standard treatment for lupus nephritis, we can actually consider plasma exchange and immunoadsorption, as well as IVIG, which has been shown to be efficacious in several small uncontrolled studies. So why do we worry about resistant lupus nephritis? We have these data from the collaborative study group. So if you achieve complete remission, the patient and the renal survival at 10 years is 95 and 94. Great. Partial remission, not so great, 76 and 45% respectively. But if there is no response to therapy, patient survival is only 46% and kidney survival is 13%. Really bad numbers. So that's why we should always try to get at least partial remission, if not complete remission. So I'm just going to end my presentation by talking about what happened to specifically to my patient. So she was referred to me to nephrology after rheumatology. Our rheumatology colleagues tried different things. So at that time, remember, she was having her maybe 4th episode of severe AKI and severe proteinuria. We're talking about a ratio of 2,500. So I reinitiated her steroid therapy at a higher dose. I added hydroxychloroquine, which she was not on for since the diagnosis, so it would have been maybe 2.5 years. And the reason being the patient is G6PD deficient. So I want to spend some time on this point. So we have to keep in mind that not all medications are contraindicated in G6PD deficiency. So if you read about each and every medication, there are medications like, for example, rasburicase, which is used by our hematology oncology colleagues, specifically tells you G6PD deficiency, don't use this medication. But there are some medications like hydroxychloroquine and cotrimoxazole, which we use in our practice. It says use with caution. So I used it here with caution, and nothing happened. Okay. Diuretics, she was in severe nephrotic syndrome, and actually I find that diuretics help a lot when patients present with acute kidney injury in the context of severe nephrotic syndrome, possibly because the AKI is because of nephrosarca, so diuresing them helps with that. And once her creatinine improved to a reasonable number, like around 130, let's say, I started her on tacrolimus. And tacrolimus, you have to remember that there is no fixed dose. You have to monitor levels, and you have to increase the doses to reach to a target trough level. There is no clear target trough level for GNs. Some papers mention 5 to 7. I think 5 to 8 is appropriate. In this particular patient, I was really aiming for actually 7 to 8. And this is what happened to her. So creatinine in August 2022 was 130. February 2023 was 70. Urine protein creatinine ratio was 2,700 in August of last year. February was 130, and her serum albumin was 18, and in February was 37. This is a summary of what we discussed, but because of lack of time, I'm going to skip it. And then I just wanted to show you I don't know what happened. The last 2 slides, please. Yeah, so this is a slide that I found in a review paper on novel therapies for lupus nephritis. So you can see that it's not showing, okay. So you can see that all of these are future actually treatments for lupus nephritis. 2 of them are already approved, which is the belimumab and the voclosporin. And then my last slide is, this is a table that I also found in a review paper. These are actually all of the current clinical trials that are studying novel therapies in the management of lupus nephritis. And some of them actually will end as early as this year or next year. So who knows, maybe in the future meeting, we'll have a lot more options either as first line for lupus nephritis or as rescue therapies for patients who are resistant. Thank you very much.
Thank you, Dr. Ali, for this nice and elaborative talk. I'm sure this was a very complicated case.